Skeptic Zone, a miracle of technology. A universe of reason, the Skeptic Zone.
Hello and welcome to the Skeptic Zone, show number 52 for the 16th of October 2009. Richard Saunders here with you. Today's episode of the Skeptic Zone is given over to an extensive interview with Professor Ian Harris by Eran Segev. This is a fascinating interview, Ian Harris being an orthopedic surgeon. Eran really gets to the nub of many important questions regarding our perception of modern medicine, scientific medicine, and I think you'll find Ian Harris's responses very interesting. In fact, I invite you after the show to click on the comments link at www.skepticzone.tv and give us your thoughts about this interview. Before we start the interview, and a quick announcement, don't forget the Australian Skeptics National Convention is going to be held at the end of November in Brisbane, Australia. Please come along and see us all. Should be a great convention. More details at www.skeptics.com.au. And while you're at the Skeptics website, don't forget to subscribe to The Skeptic magazine from Australian Skeptics. Okay, sit back, have a nice ginger beer. Yes, have a nice cool drink of ginger beer and enjoy this interview with Ian Harris by Eran Segev.
Ian Harris is a professor of orthopedic surgery at the University of New South Wales and the director of orthopedic surgery at Liverpool Hospital in Sydney. Ian has also studied epidemiology and is particularly interested in the assessment of the efficacy and safety of medical interventions. I met Ian at his office in Liverpool Hospital to talk about how surgical techniques are assessed, but ended up having a lot of what I thought were facts about medicine in general challenged. So much so, in fact, that a few really important issues had to be covered after the interview. Listen at the end of the interview for some more information. But now, here is Professor Ian Harris. Professor Ian Harris, thank you very much for joining us on the Skeptic Zone.
My pleasure.
I would like to speak today about surgical techniques and how they might be verified. The skeptical community will, by and large, people will know about how double-blind tests are done on drugs, but it doesn't seem like surgical techniques necessarily lend themselves to this kind of study. Is that correct?
That is correct. And that is a fact that can be used to the surgeon's advantage by avoiding such trials. The bottom line is that randomized trials can be done in surgery and are being done in surgery. However, there are logistical problems with randomized trials, particularly when it comes to blinding, although there have been some very interesting examples where that has been overcome with interesting results. And I recently published an article on the need to be doing sham surgery for such trials in the Australian New Zealand Journal of Surgery. Sham surgical trials have been done in the past. Whenever they've been done, they've always shown that the surgery has been not effective. And I think that there's a role for doing them. Whenever it's raised in the surgical community and you say, well, look, we're unsure whether this technique is really beneficial, we need to do a proper study where the patients are blinded and they undergo some kind of sham surgery. The answer, normally the knee-jerk response, is that, you can't do that, it's unethical. But there's a bit of confusion, I think, with the ethics. There is the ethics of medical practice, of treating patients, and by and large in surgery, one of the codes that we live by is to do no harm. So when in doubt, we try and avoid harming the patient in any way. And so on the surface of it, to do a sham operation is in some way exposing patients to risk, although sham operations can be done in such a way that there's quite a low risk. but you're exposing the patient to some degree of risk and yet not offering them any real tangible benefit. And so it appears that a sham surgical trial goes against the ethics of medical practice. However, it does satisfy the ethics of scientific investigation, which is really to perform the best possible unbiased study that we can in order to investigate something properly. And it's well known, and in the past it's always been the case, that scientific investigations in medical devices and even drugs and things like that may involve some small degree of risk to patients without any tangible benefit. And the ethics gets broader as well, because epidemiologists will argue with surgeons saying that it is unethical to be operating on patients without randomised controlled trial evidence that what we do is beneficial. So it's really turning it on its head. The surgeons will say it's unethical to do a randomised trial, and the epidemiologists will say it's unethical to be operating without one. And I think that history supports the epidemiologists, unfortunately, and you have to believe me because I'm a surgeon saying that. And because in the past so many operations have been shown to not be as helpful as we once thought they were through, good studies that were done.
Now, if I'm not mistaken, in any case, when a patient enters a study, they sign an informed consent in which they know that they might be subjected to sham surgery.
Sure, yeah.
So the patient is involved in the decision. It's not like you're inflicting harm on a patient who doesn't know what's happening.
Yeah, definitely. And all the studies have properly informed consent that is vetted by an ethics committee. The trouble is there's this knee-jerk response, and I sit on an ethics committee here at the hospital. If you say to people on an ethics committee, we want to do a study involving sham surgery, they go, well, you can't do that. It's just the automatic response is, well, you can't do that. You just can't do it. But when you actually sit down and explain it to people, they can see the benefit of it. The problem with the patient signing the consent is there's this presumption of therapy. Even though you can sit down and explain to patients what's going on, they're assuming that because the doctor is treating them, that they're providing them with some kind of benefit. But you're right. In these sham surgery trials, it is explained to the patients that you may be randomised to an arm of the study that will afford you no possibility of benefit.
Physical benefit.
Yes. Yes, yeah.
Because we do have the placebo effect after all.
Yeah, that's right. And that's the thing about surgery. Surgery has such a strong placebo effect. So there's been studies which have, some fascinating studies in medicine looking at the strength of the placebo effect. So, for instance, if you're doing a trial and you deliberately make it known to the subjects that the drug they're receiving is, or make them believe that the drug that they're receiving is very expensive, you will get a much better placebo effect than if they think they're getting a cheap drug or an old drug.
I believe there's also a color effect. If I remember correctly, I think it's the same. May even be the same study that showed that the color of taking a tablet or a pill, the color of the tablets actually has an effect as well.
Yes,
so it has accessible.
And it's the way it's sold to the patient as well. So surgery has all the hallmarks of having a massive placebo effect. It's got a huge investment in trust, cost, time, risk, everything from the patient to go ahead with this. They have to go through a lot of procedures before they even get to the hospital, sign a lot of forms, consent forms. This is a big operation you're having done. And then they go to this institution, this hospital, where they have to get undressed and changed. They get checked and double-checked. They get needles, injections. They have a huge cut. They have drips afterwards. And it's a hell of a big procedure to go through. And so I think their mind must be telling them they better get some benefit out of this. There must be some kind of why else would they do it? And so you've really got to overcome that. But I think we need to do more studies in surgery with a sham.
Well, one such sham surgery-based study that I seem to recall, it has to do with arthroscopic surgery for the knees.
Yeah, that was a great study. This was that was reported in the New England Journal of Medicine a few years ago. And what they did is they took a whole bunch of patients who had mechanical problems with their knees. And I think these were older patients. I think it was a Veterans Affairs study in the US. And they had symptoms which would often result in having an arthroscopy done. And I think they may have had a background of osteoarthritis in the knee, but with mechanical symptoms. And the theory is that you operate on it, you find irregularities in the knee or rough patches or torn cartilages, and you take them out, and that smooth things over, and it gets rid of their symptoms. And so what they did is a study where the patients in the sham group actually got incisions in their knees, and an arthroscopy is a fairly it doesn't involve any stitches. In fact, it's just two small holes in the knee. A camera gets put in, and you do it all remote. So it's not a very invasive procedure. So it's easy to do a sham on that. You just have to make two little cuts without any stitches. The infection rate's extremely low for such a procedure. It's not a really big procedure, and I think that they offered some theoretical benefit to the sham group, because I think they washed out the knee, but they didn't actually do an arthroscopic procedure on them. And apparently there was a documentary on it on the Discovery Channel, which I would love to see, but I haven't seen it. But it shows patients who've had have been in the study, and they're now playing soccer with their grandchildren and saying what a fantastic procedure it's been, and yet
they were in
the sham group. Yeah, so but that study showed no difference in the outcome between the sham group and the arthroscopic group. That study opens up a lot of questions, because that study, I would say, has not changed practice one bit. And that's surprising.
Is this just in Australia, or would you say that's worldwide?
Worldwide, yeah. Particularly where there's private medicine, where there's an incentive to operate, and there's an expectation from the patients to operate, and it's a customer service environment. So in the private sector in Australia, a patient with some clicking and mechanical symptoms, perhaps locking in their knee, who presents to an orthopaedic surgeon will expect to have an arthroscopy, by and large. They'll be referred there from their general practitioner for an arthroscopy. The surgeon will not have much else to offer them except an arthroscopy, because there aren't that many alternatives. They probably would have had a course perhaps of physiotherapy or tried some anti-inflammatory tablets, and so it's really like, go away, I can't help you, or we'll do an arthroscopy. And I'm trying to take the side of the orthopaedic surgeons here, but go away, I can't help you is not very good for your practice, and the patient will go to the next orthopaedic surgeon down the street and get their arthroscopy done. So by and large they just get done.
Well, as long as nobody offers them homeopathy, that's fine. In this respect, I should probably ask you, so are you a clinical surgeon as well? So do you operate, right, as well as, but you're also, it says clinical academic on your badge, so does that mean you conduct studies in addition to that? Yeah. So what kind of proportions of your day? Oh,
roughly 50-50. So I started out as medical training here in the University of New South Wales, and then did orthopaedic training locally, and then started practice as an orthopaedic surgeon. And my area of interest is in orthopaedic trauma, so it's mainly fractures, broken bones, car accidents, motorbikes, things like that. And I was happy doing that, but unhappy with the science behind what we did, particularly in surgery. but I also found that I had a poor understanding of the science behind it. My own understanding of the scientific method wasn't very good, and it isn't taught very well in medicine. So I tried to get an understanding from mentors and other people who seemed to be able to critically appraise the literature in a scientific manner. So I tried to learn that. So I eventually did some courses. Then this led me to study clinical epidemiology, which is basically, evidence-based medicine, the science behind the studies that we do. And so I did a master's degree in clinical epidemiology at the University of Sydney, which is it's a very good course run by the School of Public Health there, and the people there are all good skeptics. They're all very, very soundly scientifically based. And then I did a PhD in surgical outcomes at the University of Sydney as well. And then so that led me on to do other research projects, and now I have students working for me, and so I split my time between the academic activities. I'm employed by the University of New South Wales, and the clinical activities, which is looking after patients that come into this hospital. And the two cross over. We do studies on the patients that come in here.
Have you found that having studied epidemiology and being much more aware of how the scientific method can inform the way you treat patients, has that changed your practice?
Definitely, yeah. I was always a little bit wary, but I would be probably the most conservative, one of the most conservative orthopaedic surgeons around. So when I go to meetings, I go to a lot of clinical meetings and meetings with other surgeons, things. I would tend to take up one end of the spectrum, which is the non-operative end, whereas some other surgeons, it varies a lot. It can be quite aggressive and operate on a lot of patients, where I would not operate on them. And that's because my interpretation of the evidence is such that, from my experience and from my understanding of the literature, if there is not good evidence for a procedure, then the procedure probably doesn't work. Whereas their default position is, well, we know from experience in my hands that this procedure works, so until evidence comes out that shows me otherwise, I'm going to continue doing it. And this is medicine for the last 100 years or 200 years, is that people, right back to the 1800s when they were doing bloodletting and venesection on everybody, and they finally came out with the evidence that it didn't actually offer any benefit, people still did it because that's what they did, and they saw patients get better after they did it, not realising, of course, that patients tend to get better anyway.
Are there cases where surgery might be obvious, where you think studies are not required? I can give you an example that I might think of.
Yeah.
A broken bone that hasn't set properly.
Yeah.
Oh.
Well, this is my field, and I think subconsciously this is what's drawn me to my particular area of super specialty within medicine, which is basically fixing broken bones, because it's such a clear-cut sort of black and white area. However, within this field, the evidence is still questionable for a lot of the things we do. And I spend a lot of time arguing with patients who come to see me with a broken arm somewhere, and the X-rays never look perfect. I mean, if you treat it non-operatively, you still see the fracture, and it's just roughly lined up, which is fine. And but I have to argue with the patients because there's this expectation. The patients say to me, "But doctor, how is it going to heal if you don't put it together? Unless you operate on it to put the bones together, it will never heal." This is what we have to deal with. This is the understanding of a lot of people, and I have to go back to them and explain that bones have been healing for hundreds of millions of years without operations, and quite successfully. And evolution has has worked out over several billion years a way of making bones join together, which is quite unique and extremely involved, and involving hundreds and thousands of mediator factors and proteins and local chemicals to make this process work. When we operate on it, we completely just remove all of those factors that are in there helping it heal, and by and large, when we operate on things, probably the chance of bones healing is lower. One of the reasons we operate on bones is not to get them to heal. When we operate, it's normally to hold them in a position such that when they heal, the function will be better.
So it's to deal with the functionality post-injury rather than with the healing process?
Yeah, that's a large part of it. However, there are examples where bones are very badly broken and you can't control them. You know, a classic example is probably the femur fracture. So the thigh bone fracture is a good one. Forever they've been treated in traction. And I remember at this hospital when I came here as a junior many, many years ago, there was a doctor still treating them in traction. And in World War II and in the 50s and 60s, there were whole wards full of young motorbike riders who were in traction for months. Now, they all healed, and they healed satisfactorily. They probably healed, a lot of them healed with a bit of deformity. So they healed a bit short and slightly crooked, and so people had a bit of a limp afterwards. So I think our modern methods these days where we operate on them probably gets better function. But the other thing is, the imperative is that to leave every patient with a broken femur in hospital in traction for 3 months is just not possible these days. I mean, the cost to the hospitals, the cost to the patient being out of work, not being at home to look after their kids and everything, to put someone in hospital for 3 months is unthinkable these days, whereas it was just a matter of course in those days. So we operate on every single thigh bone, every single femur fracture that comes in, and we fix them and they go home normally within a few days. But we've increased the infection rate because of that, because they never used to get infected.
So did the traction work there?
Yeah, they always used to heal in traction.
Yeah.
And they never got infected, but they would have probably more residual deformity with that, because it's difficult to control the alignment in traction. It's easy to control the alignment when you put a big metal rod in there. Yeah. You know, but still the belief in surgery is so great amongst the, people being operated on and the surgeons themselves. And I often have a bit of fun with the junior doctors when they come through to learn about orthopaedics. One big area of orthopaedic surgery is the hip fractures in the elderly. It's an extremely common condition, and most people have a grandmother or an auntie or someone who's had a hip fracture and had it fixed or had it replaced or pinned or whatever. It's very common. We would do that operation every day in most hospitals in the world. Yes. And they all undergo surgery. Whereas in the old days, a lot of them were treated in traction or other ways. But there's this belief that without surgery, these patients are somehow doomed. And there's an urgency associated with the operation, and a lot of surgeons believe that the patients have to be operated on immediately or within 24 hours, otherwise the mortality is unacceptable, and if it's left more than a few days, then the patients sort of deteriorate, and it's really quite an emergency. And I often say to the junior doctors, so what would happen if we treated this fracture non-operatively? If we treated it, say, in traction? And they often kind of just laugh at me, just think I'm having a joke. And I go, no, I'm serious. What would happen? And they go, well, the patient would die. And I say, well, really? What would they die of? And, they'd be immobilised in bed, so they would get bed sores and pneumonia and urinary tract infections and terrible complications, and they would the patients would deteriorate to such an extent. They're elderly anyway, and their reserves aren't as good, and they would basically die. The only randomised control trial that's ever been done was done some time ago, and it randomised patients to traction versus surgical fixation for hip fractures in elderly patients. there was no difference in the mortality between the two groups.
And that's when it's quite obvious. The difference would be quite obvious to the patient.
Yeah.
So it's not blinded. It's
not blinded.
It's randomized and controlled, but it's not blinded.
Yeah, it's not blinded. So you're going to be treated non-operatively. You're going to be treated operatively. But there's no difference in the mortality. You're no more likely to die if you get treated non-operatively than if you get treated operatively. And yet, if you tell surgeons this, they don't believe you. Most of them aren't even aware of the study that was done. And the same thing with the urgency of the procedure. If you look at the literature scientifically, and if you control for the general condition of the patient, there's really no difference if you operate on it within 12 hours or 24 hours or 48 hours or probably 72 hours. In fact, that randomised controlled trial that I mentioned shows you that there's no difference in mortality if you never operate on them. So it's hard to argue that you need to operate in a certain number of hours when we know that if you don't operate at all, it doesn't make any difference. And a lot of these studies tend to be biased because the patients they're not controlled trials. So the patients who get operated on earlier are the fitter and healthier ones who are fit for the operation. The patients who are medically unwell and need some workup and transfusion or a pacemaker or something like this, they're the ones that get operated on later, and they're going to have a higher mortality anyway because they're sicker. So,
but good studies would actually isolate the variables.
Yeah, and the better studies that isolate the variables and allow for this do not show this dramatic difference in mortality that the poorer studies show. But unfortunately, a lot of the people who are making the decisions about surgical treatment don't have the skills and the will to get to the bottom of the literature. And, you know, I guess to be fair to them, I mean, there's data out there on how many medical articles are published every day, and in order to be ahead of the medical literature, you would have to read for, 48 hours a day or something just to stay on top of everything that's coming out. But the evidence is there if you look for it, and if you know where to look. There's good summaries of the evidence and Cochrane reviews and things like that, which are very helpful.
So how do you change that culture of preferring clinical judgment over science and studies?
That's a very good question, because that's what we need to do. We need to have the decision makers, the doctors, basing their decisions on better science and have them able to interpret the data better. Okay, the first answer to that question is it is changing. So a lot more people are savvy to the scientific side of things and evidence-based medicine, and particularly for reasons I'm not sure of in the United States and Canada. So in North America, they're a lot more aware of these things. And it has changed a lot in the last 10 to 20 years. So it is changing. I would say the same thing for Australia and the UK. Other countries I can't really comment on. But so what is it we're doing to make this change? There's probably a little bit more emphasis on evidence-based medicine principles in undergraduate medicine. It becomes a kind of self-propagating thing that people get interested in it, and so they teach younger people about it, and they become aware that this is the right way of seeing things, and so they teach other people, and it kind of spreads by influence. And we've made an effort in the College of Surgeons in Australia now has a course which is done by most young trainees, which is a course that I'm involved in, called the CLEAR course, which stands for Critical Literature Evaluation and Research, which is basically just a 2-day summary course about evidence-based medicine. But I do sometimes question the effectiveness of that course. I think sometimes people will get really have their eyes opened by it and are very open to it, and it changes their practice. But some people just sit there and they're only doing the course because they have to get it ticked off on their CV or something like that, and so it can be hard to get through to some people.
What about, you mentioned earlier that doctors are not actually trained very well in the scientific method while in medical school. Is that something that you believe can be changed or is changing?
Yeah, I definitely think it can be changed. I believe it is changing, but it's a bit hard to keep track of because I'm not directly involved in the course curriculum for undergraduate medicine. And now, particularly in New South Wales, in the last 5 years, we've seen an extra 1, 2, 3, 4, 5, I think, medical schools open up. And I have no idea what they're teaching. But there's so many, when I went through, there was only 2 medical schools, and now there must be 7 or 8 in New South Wales.
But I assume that there is a core curriculum for medicine required for registration in New South Wales?
I'm not sure, because I know that the course does vary a lot between the universities. It varies quite a lot. So I'm not sure whether there's a core curriculum. I don't think it's like the HSC or anything like that where you have to cover set things.
That's actually a bit scary because nobody with just an HSC would come near me with a knife.
Yeah.
Well, hopefully, but doctors.
All you have to do to be registered is have a medical degree. In order to get your medical degree accredited from the university, so say for instance University of Western Sydney, which has opened up recently, they developed a medical course from the ground up. Now, this is where it's not my area of expertise, but I assume they would have had to have their medical course accredited. What I can't tell you is how stringent that is or what criteria there are to have a medical course accredited.
It'll be interesting to try to find out who the accreditation authority is, who's on it, and how they evaluate the courses.
If you find out, let me know, because it would be interesting.
Yeah, I think it's very interesting, and it probably leads up to my next question, which is to do with public demand. One of the things that we as skeptics do is try to educate the public how to think critically and not take claims at face value, and try to explain to people why, while science is definitely not perfect, it's the best method we have of finding what's true and what's not true. And of course it's very true in medicine, scientific medicine. And I'm wondering whether educating the public to demand of the doctors, demand of the authorities that treatments are based on science would be a good approach.
Yeah, I agree. I think the public should be educated better. I don't know whether they should be able to look at some of the evidence themselves or have some kind of access to the evidence behind the procedure that's been recommended to them or the drug that's been prescribed to them. I think if they ask the doctors, then there will be a tendency to get around it by saying, oh yes, the evidence is very good, here's the tablet. Because the patient's ability to interpret the evidence might not be very good. The doctor's ability to convey the relative merits and strengths of different studies to a patient might be very difficult. So, in essence, it's going to come down to just trusting the doctor's opinion again, probably.
There's this thing. I'm actually not so sure that I would like to believe that that's the case, and I'll probably explain why. They always say half the population has below average intelligence, but also half the population has above average intelligence, and half the population has above average education levels. And you don't have to educate 100% of the population, but if you have, say, 25% of the population who are able to understand what studies are all about and are able to ask the doctor, what's the evidence for this treatment that you're recommending to me, and what are the risks, what are the percentages, get into it in some detail, then you don't need 100% to claim to require that. If you have 20-25% require that, doctors will get in the habit of knowing.
Yes.
It's not even about explaining, it's about knowing the evidence.
Yeah.
And they might actually get into a mode where they treat choose treatments based on evidence because they have to explain it to 20-25% of their patients.
Yeah. I agree. Yeah, I agree. And if I go to the doctor or I take a family member to the doctor, I'm asking the questions and I'm looking it up before I go. So I have some experience with that, but it's asking the right question as well. I mean, there's a lot of things out there that in medicine that there is evidence that they work for a certain outcome, but they might not work overall. So, what are some of the classic examples? Classic example would probably be in surgery, carotid bypass surgery for preventing strokes.
Yes.
Which was very popular in probably 20 years ago or so. And if you look at the evidence of whether it reduces the risk of stroke, which is what you're interested in, then it looked very good. That's if you excluded the patients that died from the operation, or perhaps had an early massive stroke, things like that. So, in the end, when you looked at it, it was probably worse off.
It's a funny way of looking at it, though, eliminating those who died from the procedure.
It's the old thing of disease-specific mortality. I'm always having this argument. This is a real epidemiological argument, because if you look at a lot of treatments, they are very good at reducing the disease-specific mortality. So if you've got a treatment for breast cancer, say, like radiotherapy, I think if you look, there has been studies done, if you look at radiotherapy for breast cancer, it dramatically reduces the risk of dying from breast cancer. And so that's it, end of argument. I mean, it just sounds like...
But radiotherapy is carcinogenic in its own right.
Exactly, but it increases the risk of dying from other things. And so the actual risk of death after 20 years with or without radiotherapy is probably not a whole lot different. And same thing with, this is the debate that goes on with mass screening for things, because it'll reduce the disease-specific mortality. So mammograms for breast cancer, which are being pushed in this state anyway, and in a lot of places, because it sounds good. I always say this to my students: if something sounds good, if it sounds biologically plausible, then I'd say odds are it's probably not true, because you can make anything sound biologically plausible. And whereas that's what we used to hang our hat on in the old days, was making a biologically argument for something to justify yourself. Now I think you can make a biological argument for just about anything, and that's what people do, and time again it gets shown to be not the case. I mean, I can't believe how people are so adamant that mammography, breast screening, is saving countless lives. When you look at the evidence, it's very questionable. I mean, there's a lot of debates written about this in the BMJ. Studies of hundreds of thousands of patients randomised to mammography versus no mammography in Scandinavia. I think another one from Canada. I think all of the studies have shown a decrease in disease-specific mortality, because you're diagnosing breast cancer in so many more people. You're just not saving any lives. So the risk of dying, period, yes, in some of these studies were the same in both groups.
So that includes, obviously, a look at the life expectancy, not just because we all die.
Yes, 100% mortality. Yeah. But over a certain period of time, the mortality was the same. And in one of the Scandinavian studies, the overall mortality in the time period looked at was actually higher in the mammography group than in the control group. So you were less likely to die of breast cancer, but you were more likely to die.
How could something like this be explained? It doesn't seem... it doesn't seem to make sense, because mammography is not even a treatment.
Yeah, well, the theory is that, it's an interesting thing about the disease-specific mortality, because what it does is it probably overdiagnoses. So you're picking up so-called breast cancer in patients that would never present, would never normally be diagnosed with breast cancer, maybe die of something else first, maybe never get it to a stage where it's clinically apparent or causing them significant concern. So in the mammography group, the rate of breast cancer is going to be hugely higher. So your disease-specific mortality is going to be lower, because the only people that die of breast cancer in the non-mammography group are people that actually really have a cancer that's causing problems in their breast. Whereas the other group, the mortality may be the same, but half of them have been diagnosed with carcinoma in situ, or all these sort of new diagnoses which never used to be called cancer before, or something like that. So they lower the threshold of what is a cancer.
And of course, Les Erwig also has done research on, or is doing research on monitoring specifically, I think also specifically about prostate cancer, or at least that's one of the areas that he's looking into, and I think the results are very clear there as well, that monitoring leads to overdiagnosis and overtreatment.
Yeah, it does, and there's also the psychological harm. In the Scandinavian study of mammography, something like some tens of thousands of patients were falsely diagnosed with breast cancer, and some thousands of those people ended up having a procedure. So they thought they had cancer, they ended up having to have a biopsy or an excision or some kind of procedure. And the psychological side of that is huge, and it's all unnecessary and to no net gain. And yet there's a political, a sort of a social side to this, that if somebody gets up and says, I think we should stop mammography screening because the evidence behind it isn't really very good and we need to rethink it, or at least let's look at the evidence more objectively, and it might not be a good thing, you can't do that. You can't get up and say that. Yeah. They had a one of my favourite programs is Norman Swan's Health Report, which is very good. I mean, I don't know Norman personally, but I can tell you from a scientific standpoint, he is excellent. He asks all the right questions and looks at the evidence really well. And they produced, I think it was Alex Barrett that actually did it.
Who is a collaborator of Les Erwig.
Yes, she's at University of Sydney School of Public Health, and that's where I did my clinical epidemiology. So that's why I know Les and Alex. They're very good there. It's a great unit. But presented a very objective look at breast screening. And yet copped enormous flack from Breast Screen New South Wales. How dare they publish such, broadcast such an irresponsible article, and think of the countless lives that are saved, every day from this procedure, and how could they dare to question the standard practice?
I think it probably talks to the lack of understanding of how science works in large parts of the population, including people who should probably know better.
Right. And this is the problem with it sounding good, because it's hard to argue against people. You say, you need to have a mammogram because you may have breast cancer because you're a woman and breast cancer is very common. The only way you really know is a mammogram. It's a much better test than it is just trying to diagnose it yourself. And if we diagnose it, we can treat it perhaps before it becomes a problem. And I mean, it's just hard to argue against that. I mean, it's just so logical. And yet, it really doesn't bear out. And there's lots of reasons why it might not bear out. And there's a lot of interesting kind of fallacies and biases that can be built into this. Interval bias and things that are difficult to explain, but there's lots of reasons why it probably doesn't work. And interestingly, one of them is that probably a lot of the treatments that we give aren't nearly as effective as we think they are. Yeah. Surgery, for instance, radiotherapy, chemotherapy, a lot of these things aren't nearly as effective as the public believe them to be.
So, but we do see a significant reduction in deaths from cancer, for example, over the past.
No, I think if you take prostate cancer for instance, because this is a classic example of jiggling the numbers to make things look better. If you look at the survival rate, say, I don't know, pick a time, 5 years or 10 years, I don't have the exact data with me, but in the 1950s, for prostate cancer, there was it was a significant mortality associated with prostate cancer. If you were once you were diagnosed with it, there was, I don't know, let's just, for argument's sake, let's just say it was 50%. Now, over the years, we have been faced with an increase in the number of patients with prostate cancer and a significant lowering of the mortality associated with the diagnosis of prostate cancer. And treatments have changed. So on the surface of it, and the same thing for breast cancer, we're faced with an epidemic, okay, and I've heard the Minister for Health say the same thing about breast cancer. I've got a quote here that I keep on my computer because it is so ill-informed, but it was, who was the Minister, Federal Minister for Health some years ago, said, isn't this terrible? We're faced with an epidemic of breast cancer where the numbers are shooting up through the roof. I mean, everybody's got it now, whereas it wasn't diagnosed as much before, so the rate has doubled, and yet the survival from breast cancer has improved over that time as well. And so isn't this fantastic? It must be the treatment that's done it. And partly what's done it is that the threshold for the diagnosis has gone down. So as soon as you start including things that were once called benign cysts or carcinoma in situ, as soon as you start including them as cancer, all of a sudden you've increased the number of people with breast cancer. Okay, so that's what's given us the epidemic, and then you've treated everyone. Now, surprise, surprise, the patients who had carcinoma in situ do extremely well. The survival for that is very, very high, and so you end up with an increased incidence. And so the numbers they showed with prostate cancer was that the mortality fell from 50% to 5%. The numbers of people with the numbers of prostate cancer patients presenting went up, and yet the number of people who died each year from prostate cancer actually went up. So it just makes it sound good to say everyone's got prostate cancer, but no one's dying of it anymore.
So basically, we're talking about diagnosis tools being better nowadays, but treatment tools not necessarily catching up.
No, I don't think diagnostic tools are necessarily better. I think that there has been a change in the threshold for diagnosis.
But say 30, 40 years ago, mammogram didn't exist, so you wouldn't be able to see cancerous or precancerous formations.
Yeah, but how has that helped us?
No, it just increased it's a diagnostic. So I'm saying it increased the number of people who are diagnosed. It's similar to...
Although it's only really diagnosed on biopsy. So if you have an abnormal mammogram, yes, it will only lead you to have a biopsy if it's suspicious.
But so I would suspect that if you look at the number of biopsies, you'd find that they've gone up as well.
Yes, yeah, they have.
So it's to me, it's a little bit like the whole autism vaccination argument, where the anti-vaccination lobby claimed that autism is obviously caused by vaccines, and the reason is, their evidence is that as vaccination rates have gone up, so have autism. Now, yes, what happened in the world is that in certain places vaccination rates have dropped. So we had a natural experiment, a natural epidemiological experiment, where the vaccination rates have dropped and autism rates, of course, continue to rise because it's got to do with a broadening of criteria and with better diagnosis.
This gets on.
So it's a little bit. Yeah. It's a little bit similar.
This gets onto my next favourite topic, which is medicalisation. I don't know how many kids or families I know have autism now. I mean, nobody had it when I was a kid. Now everybody's got some degree of it, and a lot of these kids do really well at school and they look fine to me, but I don't know, I'm not an expert on that kind of thing. But yeah, surely it's diagnosed more now than it was before, and it's not because it's an epidemic, it's probably because the threshold or the diagnostic criteria changed. And it's like depression, and people, I don't know, people just want to blow these things up. It's in some people's interests. It's in the drug company that makes antidepressants' interest to make depression appear to be a problem. I mean, we must be up to the stage now where 51% of the people in the world have depression, you know, and the other 50% are too happy,
So
and they need something
abnormal, who's abnormal now? Yes. By the way, this thing about over-medicalization is not something that only the scientific medical fraternity, or so-called fraternity, is responsible for. It's something that we see in alternatives to medicine as well, and where they make claims about how bad things are, but they also make claims as to what they can treat. And of course, they treat with water or with making your back click, something that has no evidence for. So it seems to me like there's a bit of a parallel here. Although I would say one thing that you have to say for scientific medicine is that there's at least the attitude that we have to show scientifically what works and what doesn't work.
I would say the big advantage that medicine has over, say, complementary alternative medicines is that it is based on science. Okay, so it's using the scientific method, and there are a lot of people, and especially the big names, and a lot of people in influence are using very good scientific methods to examine what they're looking for. The downside of medicine compared to, because you've got to say, okay, somebody's sick, they've got a pain in their stomach, should they go to a doctor or should they go to a homeopath? Okay, now your argument then is, well, at least what the doctor's doing is based on some science, even though he may not necessarily be able to diagnose them, or he may be wrong, or at least he's approaching it in a scientific manner. Well, I would argue that a lot of the time he probably isn't, but having said that, a lot of the time they are. That's the advantage. The downside is that the patient who goes to the homeopath is much less likely to have harm done to them, whereas the potential for harm being done to you by attending a hospital is enormous.
Although you might say that going to a homeopath can lead to the harm of not being treated.
Yes.
In cases where you might need to be treated.
But I think some of the time you can still make an argument that they'd be better off not being treated. Yeah. There's so many examples. It astounds me, some of the figures that come out when you look into these things. When you look at the harm done in hospitals, the deaths, unnecessary deaths, the deaths caused by medical error, medication errors, all sorts of things. It's huge numbers that we're looking at. Absolutely huge. The studies that were done out of Boston, the studies that were done here in Australia, it's just staggering how much harm. And then you present this, and the reaction to most people is just, well, they were probably sick anyway, and it's, that's just, good with the bad, and that kind of stuff.
In a very recent episode of, I have a segment called Grain of Salt on the Skeptic Zone podcast, which we're recording for right now. And in a recent episode, I actually spoke about that statistical thing, and I actually took a different approach, and I'd be interested to hear how you would respond to that. Because one of the things I said was, there's this number thrown about, 18,000 people a year die of medical error.
Yeah.
What I'd be interested to know, and I wasn't actually able to find reliable information, is how many of these people died because there was some negligence involved. They arrived at the hospital healthy or relatively healthy, would not have died other than through the fact that they visited the hospital. I think that's a very important question to ask, because if you're talking about people who came to hospital and should have been saved, but weren't, then that's a completely different approach, because then you're comparing them to alternative treatments that wouldn't have helped them. So,
well, I think that number is, I was just about to say high or low, because I don't know which way you're looking at it. But I think that most people that present to a hospital to get treated don't die. The actual death rate in hospital isn't very high.
Yes.
And so I think most of those people that died through medical error would not have died anyway. But I'd have to read the studies again. I haven't read them for years to look, because it was broken down into sort of actual sort of medication errors, and they had different categories of adverse events. But I see complications all the time in a hospital. Just errors occur all the time.
But isn't there the bias here? Okay, I'll throw that back at you, because you're a surgeon and an academic. You look at things in terms of the statistics side as well as the clinical side. And I'm just wondering, you are at the hospital and you see those complications. Could it be that you're a little bit biased and just seeing the complications? I mean, most patients just go home. A very small proportion actually have complications, I would assume. Is that, first of all, is that the correct assumption?
It depends on kind of what area you're looking at. Complications are common. Perhaps the question that should be asked is, because most complications that I see aren't death. There are other things where something wasn't fixed properly and it needs to be redone, and they didn't use the right thing here, and now something else has to be added to it, or they neglected to give them this medication and therefore they got a problem. The question there is probably the so what factor. Because it's interesting, we worry in orthopaedic trauma, for instance. I may be going off the track here, so bring me back if I am. Fixing fractures, for instance, we worry about whether the bone heals or not. Okay, and so that's what we really hang our expertise on, is we can get the bone to heal, and if we can't, we consider that a failure of treatment, and a certain percentage of them don't. I mean, if they're badly broken or whatever, and one of our common operations is to have to re-operate on bones to get them to heal. And we consider that a disaster. That's a failure of treatment. The patient's had to go to hospital again. They've had another procedure. It's quite a big deal. And so we consider that a bad thing, and I think that should be avoided. However, the patients don't. The patients don't necessarily see that as a bad thing, and I've done some satisfaction surveys where the patient satisfaction is completely unrelated to whether they have a complication or not, or whether they need to have another operation. It's completely unrelated. And to give you an example, if I had a patient that I did an operation on and I pinned their broken bone, and the next day I saw them and their leg was twisted and it was in the wrong position, and I had done the operation incorrectly, and they had to go back and have another operation to redo it. Now, that's an adverse event in any person's book. It's a complication. You may even call it negligence or not, no attention to detail, but it's a bad result and it's required another operation for the patient. However, by and large, patients will be very good about things like that. So if I say to the patient, look, we've done your operation and your bone has been stabilised, but if you look at your feet here, if I just explain to you, you can see there's some malalignment. It's not quite right, and I think that should be corrected. In fact, the x-rays show that it's out by a considerable amount. And what I'd like to do is take you back, re-operate on you again, and I'm very sorry this has had to happen, but it has, and what I'd like to do is remove some of the screws, realign your leg, and reinsert the screws again in a better position. And we can do that for you as soon as we can. We'll book it for tomorrow morning, but it'll mean you'll be in hospital for a couple of extra days, and you do have to have another operation. But most patients are fine about that. They really don't mind, which is interesting, So when is a complication a bad thing? Most patients are happy with that result, and they will leave the hospital satisfied. However, if they get a good operation and I'm rude to them, or I don't see them afterwards, I don't answer their questions properly, I'm dismissive of them, they will be completely dissatisfied. They will be dissatisfied with the operation, with the results of the operation, with the look of their leg, with the scar. They will be dissatisfied with the whole procedure. Whereas the other patient who's now got 2 scars may be completely satisfied. Look at how well those 2 scars healed up, and the doctor was really nice to me. So it's interesting about complications. So that's why we probably have to bring it to more objective things like death.
Yeah, well, death is absolutely objective, but also, and I think in that respect, we should probably look at life expectancy. And I think one of the things that to me are the clear indications of the success of medical science is the difference in life expectancy between places that do have...
I disagree. I disagree that the difference in life expectancy is due to medical science. And that's been looked at, and in some studies they say that probably the proportion of the difference in life expectancy due to medical technology and medical science is maybe of the order of 10%, and most of it is due to nutrition, clean drinking water, good food, healthy lifestyle, that kind of thing, rather than to the heart bypass.
Isn't China a good example of not? Because in China the main difference is actually not, there's increased urbanization, probably a life that's a little bit less healthy. Are you going to show me something on your...
No, you keep talking, I'll show you something. Yeah.
Okay. Yeah. Should probably tell our listeners that Ian has just pulled out his laptop and he's looking for some information. I've done, the deepest type of research. It's called Googling, and what the information I found was that things like clean water or nutrition have not actually changed dramatically in China over the past 50 years. But what has changed, penetration of Western medicine into rural areas as well as the big cities. And there was a suggestion that has significantly contributed to...
I'm sure I could find an example where it hasn't happened as well.
Okay.
It's easy to pick somewhere where it has. But there's the change in life expectancy over the last 300 years.
Could you describe the graph, please?
So the graph goes up from, I think that it's not exactly marked, but under 40. So a life expectancy of under 40 in the year 1700 to pushing 80. Around,
and that is where?
The year 2000.
Yeah, but in where?
I wish I could remember where I got this from. I think it's from the UK, actually. Where I got
should probably say, by the way, that people were not dropping off at the age of 38.
That's right.
More people were dying young.
Yes,
there were people dying at the age of 90, but there were also a lot more people dying.
Infant mortality was very high, and that skews the figures a lot. Yeah, but what you can see is that ever so gradually the life expectancy has increased over the last 300 years. Yes. And it's been increasing steadily, and it's probably plateaued more or less compared to the rapid increase from 1700 to 1800 to 1900. And when we get to the era of modern medicine, where medicine really has actually made a difference, I mean, you've got to be talking you would say 1950 plus. I mean, no real good surgery before then. Antibiotics not until World War II plus, and that's when that's the tail end of it. And so to attribute the change in life expectancy from 40 to 80 over the last 300 years to a few medical advances in the last 50s, probably drawing a long bow. The other one is that antibiotics is often quoted as the famous one. Well, I'll show you another trend, a 100-year trend showing the gradual decrease in mortality, steady, gradual decrease over time in mortality from TB.
Yeah.
And then you mark on there where antibiotics were introduced. It made no glitch to it at all. It was just gradually getting better anyway.
The trend of the graph continues uninterrupted. It's a downward trend from 1900 to about 1980.
Yeah.
And then actually going up a little bit, but in the middle of the 1900s, when antibiotics for TB was introduced, the graph continues in a linear fashion in the same direction.
Yeah.
Okay. We're almost out of time, mostly because the tape here is about to run out. So we enjoyed the talk, and we're talking for much longer than I expected. I want to go back to the surgical studies,
okay.
And there was something specific that you said earlier to do with the arthroscopic surgery for the knees, where you mentioned it's just two little cuts, not even stitches are required. But what do you do about things that are either require a larger cut,
yes,
or where the surgery is for something like open heart surgery, like the kind of things where you do not just open the chest cavity, just in order to do something?
Well, I think they did it. I think there was a sham surgery study done a long time ago on ligation of the internal mammary artery, which is inside the chest. It's an artery inside the chest which runs along the chest wall, and it doesn't run to the heart, but it's a branch of a vessel that comes from the same origin. The theory, and again, biological plausibility, fantastic, is that this artery was to be ligated. And by ligating this artery and not having any blood going down your chest wall, it would divert the blood in an extent to your heart. So more blood would be going to the cardiac vessels rather than to this other fairly useless vessel. And so they would ligate the internal mammary artery. And it was a great procedure. It worked very well and it was accepted and widely used. Because it had biological plausibility. And then they did a randomised controlled trial where they ligated the artery in half of them and didn't ligate in the other half, and they found no difference.
That's amazing. So when you say they didn't ligate, I know, for example, in certain treatments, for example, certain types of infection, of fungal infections, what you would do is, my wife used to work in clinical studies, and she worked in this study where they compared a new treatment, new drug for fungal infections. The control was not placebo. The control was the standard best treatment of the day. I'm just wondering about something like this, where it's quite radical. You open the chest cavity. It's a significant injury, which takes a long time to heal. Do you actually then do something else, or you just open the chest cavity and then do
No,
nothing?
that's it. That's it. You don't do anything else. You've got to be careful of using the gold standard. There's a kind of a creeping error that gets into this, because something gets tested or doesn't get tested. It's just standard practice. And then something else gets tested against that because it's the gold standard, and it's found to be just as good or slightly better, and then something else gets tested against that new gold standard, and all of a sudden we've got something that's absolutely fantastic, but probably if you tested it against a sham it may not be that beneficial. But you don't have to do a sham trial. Recently they did a great study in surgery looking at appendicectomy. And still today, if you present to a hospital in Sydney with pain and signs consistent with appendicitis, you will have your appendix removed, and you will have it removed as a matter of some degree of urgency. And yet a randomised controlled trial published in the British Journal of Surgery this year, randomising patients to surgery or antibiotics, showed no difference in the treatment between the two groups, except that the complication rate was higher in the surgically treated group.
As you would probably expect.
Yeah, because they get adhesions and all sorts of late complications from having an operation. So you want to try and avoid surgery as much as possible. But there's so many areas where surgery is just not done anymore, where it used to be done before as standard. As a trauma surgeon, when I came here, every trauma patient that came in that had a bleeding abdomen had their abdomen open and had their spleen taken out and their liver packed and everything else done, and now it's rarely done. You just leave them alone. They tend to do fairly well.
And it sounds to me like you like that option. You like the fact that that's the way it's progressing.
Yeah, well, it's consistently. I'm still waiting to be shown the study that shows, this operation we're doing actually was good. And I still haven't seen that study. I just keep seeing operations fall by the wayside, but then as new technology come along, new operations get introduced without necessarily going through the same hoops.
But could that be because the studies are conducted in those areas where there's a level of uncertainty amongst the surgeons? Could it be there's a certain bias there in the results? You're saying you haven't seen a successful trial, but perhaps it's because those trials where it's quite clear that to everybody involved there's benefits, not just to a few vested interests.
Possibly, I think that's a good point. But appendicitis, that's something where there's just no argument. I mean, you ask any surgeon, you've got appendicitis, you take your appendix out. I mean, it's infected, it will get worse and it will rupture and it will... I mean, it's biological, you can't argue against that, and yet apparently you can. But no, I don't think there's much uncertainty, and even with studies that show that surgery is not necessarily required, they still operate on them.
Yes.
Even when the study's done, there's no uncertainty.
Yeah.
I don't know, it's something about being a surgeon. You have to be fairly certain about things, and you have to make decisions and stick to them.
Your hand must not shiver. That's for sure. Must not shake. We have to end now. Ian, thank you very much for being on the Skeptic Zone, and hopefully we'll have time to ask you some more questions some other time.
My pleasure. Thanks very much.
Thank you. After listening to the interview while editing it, I realized that some issues that would be important to most skeptics were not covered. So I contacted Ian again by email and asked him the following questions. 1. Since you dispute that scientific medicine is responsible for the increase in life expectancy, what benefits has it provided to society? 2. Similarly for antibiotics. We saw it had no effect on the decline in TB, yet it is common knowledge that antibiotics have saved millions of lives. Is this common knowledge wrong? If it is, what benefits has antibiotics provided? 3. We have not discussed vaccines per se, so could you tell me what you think of the debate about the efficacy and safety of vaccines? This was Ian's response. The benefit to society from medicine is an interesting question.
Taking out the question of mortality,
the knee-jerk response would be relief of suffering from things such as joint replacement surgery and even simple things like painkillers and antidepressants. Yet with recent research showing that 25% of Australian knee replacement recipients stating that they would not have had the procedure given their time over, with narcotic analgesic complications and addictions being such a problem, and with recent questions over the effectiveness of antidepressants, not to mention the increase in suicide rates in younger patients, I'm not sure how to answer that question. As always, it comes down to the balance between benefit and harm. I think that there are areas in medicine where there is clear benefit. Examples would be antibiotics for simple infections, anesthesia and simple analgesics, and immunization programs for conditions like smallpox, now eradicated, polio and measles. But we must also accept that there are areas where medicine does little good and actually does harm, particularly in my field of surgery, as we discussed. An interesting perspective on this is given by the Nobel Prize-winning economist Amartya Sen in his 2002 article in the British Medical Journal titled Health, Perception versus Observation. He noted that the quality of life is relative to what you are used to, and that people in the poorest parts of India actually rate their quality of life as similar to those in better off areas. Carl Sagan asked a similar question when he asked if we, the human race, were any happier because of science, not just medicine. Are people happier, less stressed, or more satisfied with their lot than the average person 100, 200, or 1,000 years ago? Probably not, is my answer. Specifically about immunization, I think that this is one of these areas where there is a perplexing and disproportionate response to the question of harm. Common immunizations of children have a high benefit to risk ratio, but there is a strong reaction against the potential harm at the cost of ignoring the benefit. This is perplexing because if I raise the same questions of something else topical, like cancer screening or surgery, where there is a real possibility of the harm outweighing the benefits, nobody wants to know. So this was Ian's response, and I'd like to thank Ian very much for the extensive interview and for the amount of time and thought he had given for the Skeptic Zone.
Well, thank you for listening to this episode of The Skeptic Zone. Don't forget, if you found that interview interesting, and I sure did, please come to skepticzone.tv and let us know your comments. Next week, the full show's back again with Stefan, Dr. Raichi reports, A Grain of Salt, and the Think Tank. Until then, it's goodbye from Richard Saunders.
You've been listening to The Skeptic Zone. Visit our website at www.skepticzone.tv for comments, contacts, and extra video reports.
The Skeptic Zone.